So welcome everybody. Apparently I do not have a microphone, so if you want to hear me and not be straining the whole time, some of you folks in the back might want to inch your way up towards the front, but I will try to project as best I can. Hey Amy. My name's Lisa Nolan, and I am the Director of Value-Based Purchasing at the Maine Health Management Coalition. And what I'm going to be speaking on today is some of the trends that we're seeing at both the national and state level around pharmacy spend. And then I think equally importantly, some of the strategies that the Maine Health Management Coalition and its purchaser members, as well as other stakeholders, are undertaking to try to really lower that pharmacy spend in ways that really removes unnecessary costs from the system, but really preserving that access to critical medications that are, really valuable, life-saving, and life-changing. So, figuring out a way to, sustain access to those types of medicines in a financially viable way. And two of the strategies that the coalition is working on right now, which we'll spend some time talking about, are group purchasing of RX for our members, as well as utilizing sites of care that have lower costs associated with them when you're getting those drugs delivered. So both of those are areas where we feel there are some cost reductions that can be made without in any way compromising quality or access. So they're two initiatives that we're pretty excited about. So today, again, we will start with a discussion of trends at the national level as well as Maine. Then I'm going to show you a very scary chart about the cash flow and distribution of money throughout the RX system. And then we're going to turn, again, as I said, to some of those savings opportunities that the coalition is working on right now around group purchasing, sites of care, and a couple of sort of waste reduction strategies that, on their face are fairly modest, but when you start talking about drugs that can cost several $1,000s a month, even modest changes can lead to some pretty significant savings. And then we'll hopefully have time in the end for questions. Can folks in the back hear me? Okay? Yeah. Great. So our national data is based on information from Express Scripts, which is one of the the biggest really pharmacy benefit management company out there. So all the next set of data is from them. It's not complete, the entire national picture, but I think it is very illustrative. So this first chart, and for those of you that sat in on a similar session at our last symposium, things really haven't changed much. What you see here is that this group of bars over on the far left, our total pharmacy spend over the last few years has been going up by about an average of 7% since 2013 to last year, 2016. But really the story here, I think, is if you look underneath that total spend at traditional spending and specialty drug spending, everything's being driven by specialty drug spending. Traditional is going up by just about 2% annually over the last couple of years. Specialty has gone up by 19%. Yes?
Can I ask, are the slides going to be made available?
Yes, if you're willing to fill out a survey afterwards, and be nice to me. If you give me a low score, the survey doesn't happen. Yes, they will be available, and I believe Trevor intends to get the survey out tomorrow. So if you fill it out right away, you will have this in your hands by tomorrow afternoon. Again, specialty is going up by about 19% annually over the last few years. Traditional drugs only about 2%. And just by way of sort of level setting, general inflation over that time frame, 1% a year. So, what are these specialty drugs that are driving spending? There's really no standard definition, but they tend to have a lot of the same common characteristics. High cost being one of the biggest, usually costing over $600 a month. Some estimates say that the average cost for a specialty drug is around $3,000 per month. for prescription. They're biologics, which involves complex manufacturing processes, and they treat complex conditions. And they are life-saving drugs. They treat cancer, rheumatoid arthritis, MS. They are often complex to administer as well. Some of them are oral dosages, but oftentimes the drugs are infused. You need to get to an infusion center or have a clinician delivering that drug for you. Handling around them can also be a little tricky. There are often temperature controls, and dosing and management and monitoring of those patients tends to be a lot more comprehensive than you might see on the traditional market. So when we go through the rest of this and are sort of focusing on specialty versus traditional, these are the kinds of drugs we're talking about. In terms of the RA, cancer, I mean, autoimmune diseases, any kind of inflammatory conditions, HIV, Hep C, those are the kinds of things, along with cancer, that are really the top therapeutic classes that are being treated by these specialty drugs. And if you look at inflammatory conditions, oncology, MS, HIV, and Hep C, those make up almost 30% of total spending in the specialty drug world. So to the extent those are conditions that your covered lives have, that's where the costs are going.
Lisa, did Express give you a change in the RX component of the total medical cost spend? Do they have that stat?
I can probably get that for you.
Okay.
I mean, this year, it's about 19% in 2018, I believe. By 2018, it's going to be 19%. And I'll also give you that figure for the Maine market. But it is, obviously, with medical spend not increasing at that same rate, it is inching up as a percentage of total spend. But I can definitely try to get that for you.
Thanks.
So this chart is sort of digging a little more deeply into that specialty cost to let you know sort of what's driving those increases. As you can see, in the last several years, most of the increase was due to raises in prices. The average annual increase in utilization was about 5%, whereas unit cost increases are almost 14%. But then when you look at 2016, you're seeing that it's evening out a little bit, and that it's not simply increases in price that are driving spend, it's also increases in utilization. And we're seeing that because there are a lot of new drugs available. The pipeline is extremely robust for specialty drugs. There are also new indications for existing drugs, which is bumping up utilization. And there's an aging population that unfortunately needs these drugs more than some of the younger cohorts. So, and as eye-popping as the last few years has been, Express Scripts is projecting that costs over the next several years are going to continue to go up at double-digit rates. So this is what they're looking at for 2017 through 2019. Back towards sort of the levels you saw back in 2014 when the Hep C drugs first came out. So costs are going to continue to be rising over the next several years. And again, the drivers behind that are increased price and utilization of specialty drugs, that pipeline continuing to churn out life-saving drugs, but more and more of them, and fewer generic options. And we know generic options can keep prices down, but that market is fairly saturated. So again, with this kind of trend continuing, by 2018, we expect to see that of that total pie of health spending, 19% of it at the national level will be spent on pharmacy. So, not only is pharmacy increasing as a percent relative to the rest of health spending, specialty is increasing relative to the rest of pharmacy spending. So back in 2012, your specialty drugs made up about a quarter of what you were spending in pharmacy. Now it's a little over a third, and by next year, it's expected to be half of your pharmacy spend. Now, to put this number in perspective, 1 to 2% of your population uses specialty drugs. So half of your pharmacy spend is going to treat 1 to 2% of your covered lives.
You're talking persons under the age of 65 primarily?
Correct. I'm sorry. I should have said that right from the outset. This is the, Express Scripts has Medicaid, Medicare, and commercial markets that they cover. All of these figures are based on the commercial population. If you were to, and in the back of the slide deck, you'll have the link to get to their most recent report. You can look at the Medicare and Medicaid populations as well and see how the numbers compare if you choose to by looking at the full report. So these are some of the conditions, the top drugs under the specialty side of the house, and as you can see, it's a lot of the therapy classes that I mentioned earlier: inflammatory conditions, MS, Hep C, oncology, and over on the far right, you can see what the trend looks like in 2016. So for some of those drugs, we're seeing fairly significant increases, but in a few instances like Harvoni, we're seeing pretty significant declines. But overall, the trend, as you saw on that last page, we're talking 10 to 13% increases over the next couple of years. And in terms of the inflammatory, the drugs that cover inflammatory conditions, not simply the ones here, but in total, they are expected to increase by about 30% annually for the next 3 years, according to the Express Scripts projections. So before we leave national spend, I wanted to make give you one key caveat. All the numbers I just shared with you are about RX spending under the pharmacy benefit. So that $90 PMPM is just what you spend on your pharmacy benefit. Half of the spend on specialty occurs under the medical benefit. So it's not included here. And it's not included in any of the numbers I gave you. So if you add in that specialty spend that's occurring out under the medical benefit, your costs go up by about 1/3. So when you hear folks talking about your pharmacy spend, check to see whether you're including that pretty significant amount that's being spent under the medical benefit. And like spending on the pharmacy benefit, that RX spend on the medical side has been increasing pretty rapidly as well. I think between 2011 and 2015, the growth in that medical pharmacy spend was 55%. So there too, you're seeing the increasing in costs. Some of the top spends in that medical RX, again, are anti-inflammatory drugs like Remicade, as well as several oncology and oncology support medications like Neulasta. So now let's look at things in Maine, where the picture is actually fairly consistent with what we're seeing at the national level. The numbers we're going to give you today are based on the Coalition's book of business, which covers about 130,000 commercial lives here in Maine, which is a pretty significant portion of the commercial population. At the end of the slide deck, it gives you a list of the employers and plan sponsors whose data is included in this information. So, same chart we had with our national data, and it's the same story. The total increase in RX is going up at a clip of around 7% annually, but when you pull out the traditional versus the specialty spend, you can see that the driver here too is the specialty drugs. Traditional spending is going up about the same as we saw on the national level. Specialty is a little higher, 22% I think versus 19%. So you have a little bit of a bump here in Maine, but the magnitudes are really the same. So this next chart gives you a sense of really what's driving the increase here in Maine among the Coalition's book of business. And for specialty drugs, you can see that there's an increase both in utilization, that 15.4% in terms of the scripts per thousand, as well as the price of the allowed amount per script, which has gone up 56%. So price is going up more than utilization, but they're both contributing to an overall 80% increase in allowed PMPM between 2013 and 2016. So here's one area where Maine does seem to deviate a bit from what we're seeing at the national level. In terms of the traditional drugs, as I said, we're at about a 1% increase. At the national level, that 1% is driven by about a 1%, close to a 1% increase in utilization, close to a 1% increase in price. In Maine, we're seeing a pretty significant decline over the 3-year period in utilization, almost 18%. But it's more than completely offset by an increase in price, which has gone up, as you can see in that bottom right corner, by 25%. So our aggregate number, the allowed PMPM, has gone up by 2.9%, which again is pretty consistent with what we're seeing at the national level. But when you sort of dig down under that number, the trends that are driving it are a little different than what we're seeing at the national level. Here again, I think the message is the similarity between Maine and what we're seeing at the national level. These are sort of the top therapeutic classes for a lot of these, a lot of the drugs we're seeing here in Maine. The diabetes numbers are not specialty. They're often traditional drugs, but we're still seeing a very significant spend there and an increase there. And we're seeing something very similar at the national level. Here in Maine, with an older population, we expect that number to be a little higher than what you would see nationally, and that's what we're seeing. Anti-inflammatory, again, is a really big part of that. HIV, Hep C, MS, all really the same things that we were showing at the national level. And again, a lot of these specialty drugs, it's around these small numbers. And here, if you look at those 7 classes, they make up 60% of your spend on specialty. Or on pharmacy, excuse me. So this next chart is trying to get at sort of, we've been talking about what the payer is contributing towards these costs, but this chart tries to show you as well what the patient copay is, that bright green piece on the top. And you can see that that number has, among the Maine Health Management Coalition's book of business, that number has been pretty stable and actually decreased a little bit over the last 4 years, even though total costs are going up. And what that's ended up doing is the patient contribution as a percent of the total has really declined from almost 13% down to 8.6%. So this is an area where some employers, look to, are there ways to, better share costs or, figure out different ways to redirect to less expensive drugs. But the flip side of that, of course, is around adherence. And there's a lot of studies, especially when you're dealing with these really expensive drugs, if you start putting in, higher copays, what happens to your adherence levels? But this is another area where Maine is a little different from what you're seeing at the national level. For the Express Scripts members, their average co-share in 2016 was 14.6%, as opposed to 8.6%, which we have. Although, like Maine, the average copay at the national level has been declining. And then here is my, my same caveat that I offered up around national spending. If you look just at pharmacy spend, RX spending under the pharmacy benefit for our book of business, it's 20.3% of total medical. When you add in that additional pharmacy spend that's happening under the medical benefit, it's 25.5% of spend. So a quarter of what our members are spending now is going towards pharmacy. So I'm about to switch gears. If anyone has any questions on just the trend section, or can I keep moving along? Yes, Amy.
Thanks. When the projections that costs are going to increase, what what's the rationale for that? And if more and more meds are coming out and there's market pressure to compete against one another, why do they think it's continuing to go up?
It depends what the drugs are that are coming out. If they're drugs that are entering a space and offering the same, treating the same condition with the same, like a generic, then you would expect to see costs going down. But oftentimes these are new first-in-class drugs. There are new indications for drugs that are already out there. So it's not as if all those drugs coming out are simply driving down the costs of the ones that are there already. And you know, another issue with specialty drugs is because of that complex manufacturing process, generics really aren't a thing. It's more biosimilars, which are a lot harder to manufacture, take longer, and the cost savings typically aren't as great. I mean, some of your generic drugs can be 80 to 90% less than a brand drug. But when you're talking about biologics, you're talking about maybe a 20 to 30% lower price, and there are very few of them that have made it out to market so far.
Great, thank you.
How does 340B purchasing factor into this, or is this apart from 340B purchasing?
Well, so 340B purchasing would occur under the medical benefit, because that's where hospitals that are purchasing drugs are having access to 340B pricing.
I'd like to add that there's an opportunity for people to get 340B pricing through primary care practices if they're affiliated with 340B hospitals and through FQHCs. And this can cut the cost of biologics and some of these expensive drugs. Although the overall price is maintained of the drug, there is a saving and a split that's divvied out to the hospital or primary care practice, to the patient, and to the pharmacy who dispenses it. So,
and that, I think in theory, that's the hope around some of these 340B discounts. Some of the studies that have been done to date have shown that even when those 340B discounts are available, they are not necessarily passed on to commercial payers. So even though a 340B eligible entity may be receiving those drugs at a much lower price, the commercial payer doesn't see that lower price. So that, but that is an area, as you said, it's an opportunity. The other thing to be careful about 340B, and I think it's been a real challenge for some of the federally qualified health centers, is they are not allowed to get 340B pricing on orphan drugs. And you know, you might say, well, orphan drugs, you know, how many people can that affect? Well, there are a lot of drugs that are classified as orphan drugs, but also have other indications that treat broad, stroke treatments, things like that. So they are sometimes at a disadvantage in trying to get those lower prices. But I agree, I could do an entire section on 340B. Before we get into talking about some of the strategies that the coalition and its members and other stakeholders are looking at, I wanted to talk a little bit about sort of the PBMs, the pharmacy benefit managers, and how their role in sort of the distribution of funds and drugs in the RX system. So PBMs started out around in the 1960s, and they were essentially claims processors. A lot's changed since then. In addition to processing claims, they're really designing and managing these RX programs, setting up formularies, negotiating prices, providing clinical management, working with patients. They are really much more comprehensive in terms of offering a full RX program to their clientele. Because they're really big, they can negotiate volume discounts with wholesalers and pharmacies. Sometimes those discounts, oftentimes they take the form of manufacturer rebates, which are sometimes used in exchange for a more favorable listing on their formulary. And 3 PBMs right now, Express Scripts, whose data we were looking at earlier, CVS and Optum RX process about 70% of the prescriptions in the US. And in total, PBMs process about 250 million patients' claims. So they are very much an integral piece of the RX puzzle. So how do they make money? That's changed as well. They still charge admin fees, but there are other ways that they sort of are eking revenues out of the system. One is through spread pricing. So if the teachers were paying to their PBM $100 for a drug, and then the PBM turned around and gave the pharmacy $97 for that drug, that $3 is their spread. Doesn't sound like a lot, but when you're talking about hundreds of thousands or millions of prescriptions, that adds up. So that's a piece of where PBMs can make money. And manufacturer rebates is another place. As I mentioned, they often are available. They negotiate those with the manufacturers. They don't always make, 100% of those rebates don't necessarily make their way back to the payer. Sometimes the PBM holds on to part of those rebates. And because PBM contracts are really notoriously opaque, it's sometimes hard to know how much those sorts of revenues are in your contract. What's the magnitude of the spread? You know, how many of the rebates are being passed through? You can't always tell that in the contract. There's an emerging type of PBM that's taking sort of a different approach. They refer to themselves as 100% transparent pass-through PBMs, and their model is we're going to charge you a flat fee, probably a larger admin fee than one of these other PBMs might charge, but we are going to eliminate the spread, and we're going to give you 100% of your rebates. With the idea being, with their pitch being that when you do that, you can get things for a better price. So this next chart, I have to refer to my notes because I'm not going to be able to do it without it. So I know it looks very complex and messy, but the system is very complex and messy. And I'm including it here to give you a sense of sort of where there are places in this distribution system where purchasers and others can look for opportunities to reduce costs without giving up value. So in this instance, we're talking about, and this example comes from Drug Channels, which is a great website. If you guys are interested in following what's going on around RX, I definitely recommend bookmarking that. So we're talking about a drug here that has a wholesale acquisition cost of $300 and an average wholesale price of $360. So we start out with the, let's see. So we start out with a total payment of $307 is coming from the payer, put this down, and the patient combined. And when you get up to the manufacturer, in the end, the manufacturer is ending up with $183. Okay, so we're starting out $307 coming out of the pockets of the payer and the patient, and in the end, the manufacturer comes away with $183. So this sort of explains what happens to that difference. So let's start with the payer. The payer is charged by the PBM $272 for this drug, which they pay. But then, later in the process, the manufacturer sends rebates and admin fees to the PBM. 81 of those rebate dollars and half of those admin fees come back to the payer. So in the end, the payer is only paying $185 for the drug. The patient is paying $35 still, although there are instances, not included in this example, where the patient may have access to a coupon that can defray some or all of that $35 cost. And again, coming from the manufacturer. Okay, the PBM. So the PBM has this $272 from the payer. They send $269 to the pharmacy to pay for that drug, keeping $3 spread. That's the spread for them. At the same time, when that rebate and the admin fee come through from the manufacturer, they're holding on to $9 of the rebate and half of the admin fee. So already, the PBM has gotten $18 out of this transaction through spread, holding on to rebates, and holding on to admin fees. The pharmacy gets $269 plus that $35 payment. It ends up paying the distributor, the wholesaler, $288 for a profit of, or revenue delta anyway, of $16. The wholesaler pays all but 3 of that onto the manufacturer, who starts out with $285, but again, loses 102 of that in terms of admin fees and rebates back to the PBM and the payer. So it's complex and it's messy, and it's, believe it or not, streamlined from what it actually looks like in real life. But again, just to give you a sense of the different places throughout the system where middlemen come in and take out profits from what the payer pays and what the manufacturer gets. So, now I'd like to talk a little bit about what the Maine Health Management Coalition, some of our purchasers and other stakeholders really here in Maine and around the country are doing around RX. So, you know, the Maine Health Management Coalition, as I said, we have over 130,000 covered lives among our purchasers. We also have many of the state's health plans, brokers, we have providers, all of whom are members of the coalition. So we feel like we have a really unique space and opportunity to try to come together and figure out ways to bend that cost curve around RX in ways that still maintain access to those critical medications. What are the sorts of things we can do to help our purchasers figure out ways to get the waste out of the system and make changes that can reduce costs but maintain quality. So one of the, there are 3 things that we'll be working on over, well, 2 things really are our main initiatives, which we'll be talking about today. One is group purchasing of RX, and the other is encouraging redirection of care to less expensive sites of care, or infusions to less expensive sites of care. I'll also spend a few minutes talking about some sort of modest waste reduction strategies that purchasers can undertake. And again, when you're talking about drugs that cost $3,000 a month, even a modest change can make a difference in your bottom line. So, beginning in 2018, the coalition is going to be offering to its members an RX group purchasing program. There are several coalitions, purchasing coalitions throughout the country that operate group purchasing programs. And all of these programs really have proven track records of lowering costs for their members between 10 to upwards of 40% just by switching to these group purchasing operations. And we're really pleased, you know, as the coalition started exploring whether group purchasing might make sense for our coalition and talking to some of these sister coalitions around the country, 5 of them said, yeah, it's great, we're running it all the time, and by the way, if you'd like to join our coalition, the more the merrier. Because they're getting more volume, which helps them negotiate better rates. So as we move through this process, one of the options we're looking at is potentially partnering with one of these 5 existing purchaser coalition group purchasing programs. We are also talking to some, as I mentioned earlier, those transparent PBMs that give you 100% of your rebate, don't have a spread. We're also talking to at least 2 of those who are interested in partnering with us. Yes?
So Lisa, can you say the names of which PBMs are partnering?
Sure. Well, I don't know. Let me think on that. They all have programs, except for, I think, one. They all have programs that have been in place for over 10 years, some 20 years. They're all regional coalitions, although most of them have national employers as part of their groups. And they have, some have millions of covered lives, some have 500,000. So they're large. They include unionized workforces, non-unionized, publics, trusts, privates, really the gamut of types of employer groups. So we're pretty excited about that opportunity. But we also, there are lots of benefits to joining an existing group, but there's also, we want to make sure that our members have access to a program that allows them to retain as much flexibility around their pharmacy program as they would like. So we'll be looking at some of these other standalone PBMs to see how the flexibility compares between the different options. And we are really fortunate. We have a great RX consultant who has literally, since I've been talking, has forgotten more than I will ever know about RX, and is working with us to assess these options. We're getting the RFI out hopefully in the next few days, and we'll be evaluating which of those options would be best for our members that are interested in participating. So as we look at group purchasing, there are really 3 ways that our members can save money. One is really just better pricing, switching a PBM or getting better pricing from the existing PBM, making changes in benefit design, or making adjustments to your network. And to the extent you do more than the first one, obviously your savings are going to be greater. But even sticking with that far left side, as I said, a lot of these national coalitions are showing savings of 10 to 40% for their members. And in a space where it's hard to reduce costs, if you can get your prices down, if you can get a better price to get your costs down by that much, we're really excited about having that kind of opportunity to put in front of our members. So, how do we do that? How do we reduce costs with a new PBM? Well, one of the ways, obviously, is that large volume. If you have a national, if you have a coalition that has over 1 million covered lives, they have a lot of market clout, and they can demand lower prices. They can also target some of those areas I showed you on that incredibly messy chart around spread, and demanding that those rebates make it through 100% to you. Those are the kinds of changes that, with that large volume and those expert RX negotiators that these coalitions have, that you can really get those better prices. And in terms of going with a transparent PBM, it's the same idea. They start out without any spread and passing on 100% of the rebates. So as we go through our RFI process, we'll be seeing which of these kinds of models offer our members the best price and the most flexibility to make sure that they can meet all their programmatic needs around pharmacy. So another way to further enhance what you're doing in terms of saving money on RX is to make some changes in benefit design. And one of those is identifying drugs that have the same medical and therapeutic results but are available at lower cost. So I thought I was going to give you guys a great example and talk about Duexis, but apparently Elizabeth Rosenthal stole my thunder. But I mean, the example is a good, I think a lot of people here, oh God, I don't want to make any benefit design changes, we don't want any disruption, but there are sometimes some fairly modest, very sensible changes that can make big changes to your bottom line. I mean, I think Elizabeth probably said, Duexis costs $2,000 a month, and it's Pepsid and ibuprofen, which essentially you can get for $18 a month. So benefit design, which tries to redirect folks back to that over-the-counter solution, can save you over $2,000 a month. And that's just one example. Again, when purchasers are presented, when they work with their consultants and brokers, they can be presented with some of these benefit design options, and they can make a decision around what makes sense for their population. Luckily, they have, they can have disruption analyses that can show who's being affected, how many people, and there are tools they can use, like grandfathering, if they want to help, make sure that people that are on a particular drug can stay on that drug. So there are ways to minimize that disruption. And then a third way that you can increase savings under sort of this group purchasing opportunity is through a preferred or non-preferred network. If the analysis shows that there are some providers whose costs are higher, you can set up the tiering structure so that the price differential that you see between those higher cost and lower cost providers is offset in your tiering structure, So we're really excited about this. We think it's a great opportunity for our members who are interested. It probably isn't something that's going to work necessarily for everyone. If you're a fully insured employer, it may not be an opportunity you can take advantage of just because Many of the insurance products in the fully insured market don't come with a product that allows you to carve out RX, so it may not be an option for you if you're fully insured. And another thing that we obviously need to be really careful of and certainly are cognizant of is making sure that the medical data and the pharmacy data continue to be integrated even if a purchaser decides to carve out and go with group purchasing. And the good news there is people have been carving out now for a long time. These group purchasing programs have been in place, as I said, for many years, and there's been really successful partnerships to make sure that purchasers and plans are getting the data they need to manage their patients. So, any questions on group purchasing? Sure.
Are you doing anything with like Canada RX? Are you adding that or looking at that?
I never have an RX presentation without that coming up. Right now the federal law is, it's not allowable under federal law, and it's also not allowable under Maine law. There's movement in the Maine legislature to try to get some changes in that front, but again, they would be dependent on having a change happen at the federal level as well. And there's been legislation introduced at the federal level. Your guess is as good as mine as to whether that might, move or not. There's not a lot moving there right now.
There are local TPAs that are still working with Canada RX that don't agree with it being illegal.
Well,
So-
what we've heard, and again, I think it's ambiguous, is if you're doing it and you're not doing a lot of it and you're not talking about it a lot, so no one's going to come knocking on your door and tell you to stop. But that's not an official line, but that's kind of the feedback we've been getting. So I think people are interested in it, but in terms of what's actually statutorily allowed, it's not allowable right now. But yeah, you're right. I think people look at the difference in price. It's
62%
significant.
less
Yeah,
on average.
it's a lot. No, you're right. Any other questions? Okay. Now I'd like to take a little time to talk about sites of care. So, as I mentioned earlier, specialty drugs typically, some of them are oral dosages, but typically you are getting them infused at one of at 4 places, either in a hospital outpatient setting, a physician office, an infusion site, or at your home. In the commercial market, those specialty costs under the medical benefit, half of them are occurring in the outpatient setting today. And that trend is increasing. More and more are moving into that outpatient setting. Some of the reasons for that, I think, we're seeing practice consolidation and acquisition by hospitals, which are turning some of those, what had previously been physicians' offices, into outpatient settings. Lower reimbursement rates in the physician settings, and also 340B, where if you are affiliated with a 340B entity, you could get access to those lower costs. And again, that creates that outpatient setting. So, why does it matter, where you have this done? Well, the important thing is pretty much every study that's been done on this has shown that if you get your drugs infused in an outpatient setting, it's going to cost a lot more than if you get them done at home or in a physician's office or in an infusion suite. These are just a couple of examples of studies that have shown what the cost differential is from an outpatient setting to some of the alternative places. 30% higher on oncology drugs in an outpatient setting, looking at some of the oncology support agents, which can be twice as expensive if you're in an outpatient setting as opposed to a physician's office. And intravenous immune globulin infusions were about half the cost, again, if they were done at home compared to in an outpatient setting. Now, in some instances, those higher costs are due to the fact that you're dealing with more complex patients and they need to be in an outpatient setting. But we'd like to look at use our data to try to figure out places where someone is getting those infusions in a more expensive setting and could safely and appropriately get them in a less expensive setting. So, not surprisingly, because it's more expensive to get care in an outpatient setting, shifting to a lower cost site can save significant amounts of money. A study by Walgreens, who admittedly is in the business of setting up infusion suites, has shown that switching from an outpatient setting can save up to 60% on costs. And in terms of, it's not really just a cost thing. For us, it's a value thing. I mean, not surprisingly, patients that are offered infusion at home actually decide they like it better than going to an outpatient setting. They're at home, they are not having to rely on family members to take them places, they are not in a hospital setting, they're sitting in their own living room. So a literature review of several home infusion versus outpatient studies found that patients overwhelmingly preferred home infusion. And the clinical outcomes were also as good or better than what you would see in an outpatient setting. So again, if you're talking about a patient and a drug and a condition that are appropriate to be treated outside of an outpatient setting, you can do it for less, with better patient experience and outcomes which are as good or better than what you would get in an outpatient setting. Yes?
Does that come with like a home health visiting nurse, or is
Yes.
the patient educated to do it themselves?
It's usually, because these are infused drugs, it's typically a home nurse, some sort of clinician comes into the house and delivers the medicine. The other thing, which I think is important to mention around these alternative sites of care, as I mentioned earlier, all these specialty drugs, we're talking about 1% to 2% of your population. And when folks are concerned about disruption to their members, it's a very small subset that you're talking about in terms of figuring out ways to encourage or educate them about these less expensive sites of care. They're much more easy to manage, 1% or 2% of your population, than the 40% that are on statins. So there's more of an opportunity to sort of do a hands-on, more personalized approach with folks that would be potentially involved with this kind of redirection. And here is an example of Remicade, which most of you are aware of, and probably have members who utilize this drug. This is the average claim in an outpatient setting. There's your home or infusion, and there's the doctor's office. So if you're getting a monthly infusion, shifting that patient from an outpatient to home or doctor's office can save you between $28,000 and $42,000 a year.
I think I read in Elizabeth's book that there's a big lobbying effort to require that those types of services be rendered in an outpatient hospital.
Yeah, I'm sure there are.
We find it very interesting that in Maine or across the country, we're talking about allowing a midwife to perform an abortion, but we can't do an injection by a certified personnel in a different setting.
Well, and I think, as purchasers, as the coalition and other purchasers and health plans that are already actively pursuing this kind of redirection, as they start working on those kinds of strategies and pushing them forward, there probably will be some pushback from places where care is being redirected from. And again, as I said, there are instances where you really need to be, it's clinically necessary to be in an outpatient setting. And I don't think anyone would in any way suggest moving someone. The idea here is if it's clinically appropriate to be in another place, and those sorts of decisions I think will play out as they are all over the country. And hopefully there's data. There's been lots of studies to show what the outcomes are, and we'll have to see how it plays out here. I mean, I think New Hampshire is seeing some of that now around what kind of facilities and what kind of services have to be available at those facilities in order to do infusion. So we'll see. That is something that we'll be seeing play out. Yes?
Is there data to show the total outpatient spend for those infusions versus what's happening now in the alternative sites? Like how much spend is spent?
Yeah, well,
It's like, what's the opportunity?
Yeah, so I I don't have all of that here, but you know, when the coalition starts doing some analytics around our own claims, those are the sorts of things we'll be looking at. Some of the studies that have looked at home infusion versus outpatient settings have found that other costs like infections, readmissions, things like that are actually less among patients that are getting home infusion. Now again, the caveat there is the folks that are coming into the outpatient setting, some of them may be more complicated patients who are more at risk. I don't know if they did risk adjustments on those populations, but some of those studies have shown that even those other costs can be less when someone is going the home infusion route. So not surprisingly, strategies to try to redirect folks out of that most expensive setting are on the increase. Nationwide, almost half of plans in 2016 said they were using some sort of strategies to try to help their employers redirect members to lower cost sites of care. That's up from only a quarter in 2013. So this is really an area where there's a lot of movement. And when folks are using it, they're saying that they have pretty high degrees of success. Looking at these strategies here, on a scale of 1 to 5, it was an average of over 4 in terms of getting people to get to that other site of care. So the types of ways that plans and purchasers are working to try to get people to alternative sites of care. One is essentially to require them to go where the plan has determined is a clinically appropriate setting. Obviously, if there are medical exceptions, those have to be taken into account. Another, similar to that, is to require a prior authorization in order to go to a site that's not that lower cost preferred site. Another area where, not surprisingly, there is a little less success is to contact the members and say, hey, do you know that that drug you're getting, we can get it for you at half the cost and at much more convenience for you if you have it done at home. But still, even that, I think, had a success rate of 3.5 out of 5. So just, not even requiring it, just simply educating your members about the cost differential of the different sites of care. And then the top one is, I'll get back to white bagging in a second. The top one is essentially talking about, waiving co-pays, waiving co-insurance, offering a stipend, paying for travel, all of these, different ways to encourage, monetary incentives to encourage patients to use that less expensive site of care. White bagging, again, I could spend an entire hour on that, is essentially one of the ways that costs are higher in an outpatient setting is because the drug is being purchased by the hospital, so it's a buy and bill procedure. Under white bagging, the drug is purchased by a pharmacy and sent to the hospital, so the cost is on the pharmacy side, which is typically less than what you would see on the medical side under a buy and bill scenario. So the drug is delivered to the hospital, and that's cutting down on some of the costs. Hospitals aren't huge fans of white bagging in a lot of instances. They worry about getting back to sort of that handling of the drug. Has it been properly handled? And oftentimes, particularly like in oncology, when you get into a, you go in for that appointment and you find out that the dose that's arrived via white bagging is not the dose you're going to get that day, so you have to come back. That dose is useless. So there are potentials for waste there, but today about 25% of that specialty drug is being handled through white bagging in some areas.
So, my question keeps coming into my head is, does Maine have an outpatient infrastructure to be able to provide? There you go. I did this on purpose.
Thank you. Moving me right along. And that's a good question. It's great to know that outpatient settings can be more expensive than anything else, but if we don't have alternative places to send our patients, it's not going to be very helpful for us. That's a big thing for us, moving forward as a coalition, is purchasers trying to figure that out. And again, as I said, outpatient settings sometimes are appropriate and need to be used for some patients. We also have a system that is pretty vertically integrated. Many times referring physicians and infusion centers are part of the same system. So getting a referral, a change in that referral pattern can be really challenging. And also, if you're a patient who has to go in and see your doc before you get your infusion, that can be, you could be inconvenienced of having to go somewhere else. Although, if you go home, maybe not so much. So for the coalition, and your question, I think, is really a big one moving forward. Our health plans are really leading the way here. They're starting to do a lot in this area. But as a group, our purchasers need to figure out if this is something that they want to continue to pursue. And you know, as we leverage that demand, it can hopefully secure some interest in increasing the supply, particularly out in rural areas. We have members that are spread all throughout the state. So looking for ways to work with providers in our plans, as well as the purchasers, to figure out ways to make those alternative sites available will be really critical. We also, as I said, you know, a lot of the information in terms of looking for opportunities, what kinds of infusions do we see that variation in price? We'll be looking, you know, really mining our data to try to figure that out, and potentially looking at white bagging as well. White bagging sounds like I'm standing on a street corner, but so that is another area. And again, you know, we feel like we're so well positioned because we have you know, a large number of commercial purchasers. You know, the health plans, our broker partners, and some providers, and to be able to pull together all those different folks who are already working on this to some extent and help really advance this, whether it's by making the supply available, looking for ways to change or adjust benefit design to encourage folks to use those less expensive sites. We really think that there's momentum to move forward in this area. Okay, I don't know if I'm out of time. Okay. All right, so this last thing, these are sort of examples of, you know, when I'm looking at drug channels and other sites, just picking up interesting strategies that, again, when you're talking about really expensive products, even little changes can make a big difference. So one of the strategies that some of our members are using for some drugs, not for large amounts, but for some of their drugs, are split fills. And those, essentially what they're doing is you're focusing on expensive drugs that have a lot of issues around tolerance and dosage and even efficacy, and that can cost up to $10,000 a month or more. So when you prescribe that first drug that has a 30% non-adherence rate because of tolerance issues, instead of giving someone a 30-day script, you give them a 15-day script. And for those folks for whom it's not well tolerated and they move on to another drug, you've only wasted 15 days of medication, not 30. And a problem that sort of dodged this strategy early on was the patient was stuck paying 2 co-pays. They've pretty much fixed that now so that when people are pursuing this, the co-pays are adjusted so that you pay half the co-pay with the first and half the co-pay with the second. Oncology drugs are a really big focus of this strategy. You know, costs have gone up. They were $2,000 for drugs entering the market, or almost $2,000 in 2000 for oncology drugs entering the market. They're now over $11,000 for drugs entering the market. So again, got to make these drugs available, but if they're not going to be the right drug for the patient, if you can minimize the waste by giving them that half dose, that half fill, you can save some significant dollars. One study of 15 drugs around oncology estimated, you know, $25,000 to $5,000 per patient per month by going to split fills. And so this is my last strategy, and I'll shut up. I think this is a really cool idea. So, as many of you know, when, you know, co-pays are often put in place to try to encourage patients to use less expensive drugs, to go for that generic. Oftentimes there is a coupon available which completely pays the cost of that copay for the patient, so they can continue to get the brand name drug. So the patient's sort of whole, but the payer is now left holding the bag for the more expensive brand name drug. So under a regular copay scenario, say your patient has a copay of $50 on whatever drug X, which has a total cost of $1,000. So the patient gets a coupon for, they get their $50 back in their manufacturer coupon. They don't pay anything, and the payer is paying $950. Who knows what the generic would have cost, but because the patient was able to get that coupon, they've gone for the higher cost drug. And maybe there is not a generic available. This example works either way. So under a variable copay, the patient's copay is set not at $50, but it's set at whatever the maximum amount available under the coupon is. So if the manufacturer says, well, we'll offer up to $200 for a coupon, for that patient, for that drug, the copay is set at $200. The patient still pays nothing because they're getting the $200 coupon, but suddenly the cost to the payer has gone from $950 to $800. So that's a way, again, where the patient is whole, is not paying anything, but the payer is able to recoup some of that money for that more expensive drug. So again, these are just examples of some of the really innovative strategies that folks are coming up with. That as a coalition, we are just trying to keep pushing those ideas out to our members. So as they're working with their plans and their brokers to talk about these kinds of opportunities to try to reduce their costs. So in closing, I can't believe I right on time. RX costs have been increased and they're going to continue to increase. We really, here at the coalition and all our members, want to make sure that those medications are continuing to be available to our members. It has to be in a financially sustainable way. And we're trying to figure out ways to bend that cost curve in a way that keeps those drugs in the hands of our members and reducing unnecessary costs. And for us, the focus in the next year is going to be in our group purchasing program, which again, we're hoping will offer some pretty significant savings for our members at what can be minimal disruption depending on how many changes they'd like to make, and also working across stakeholders, both within our membership and throughout the state, to figure out ways to encourage utilization of lower cost of care. So that's the Coalition's RX program in a nutshell. We have 5 minutes if anybody has any questions, or we can break early, whatever you prefer. Elizabeth?
Do you see an opportunity for doing a prevention component to this program, that is to prevent employees of purchasers to ward off the evil day of having to go into specialty drugs? I've been privy, right on the ground, of vitamin D not being supplemented after age 50, which leaves women vulnerable to the breast cancer, also the melatonin effect, and educating about depriving themselves of blue light after 9:30 p.m. Because once again, that melatonin is a powerful anti-cancer preventative. I think, do you see an opportunity?
Absolutely, absolutely. And we had an all-member meeting a couple of weeks ago where even more of the Coalition's book of business data was presented, and diabetes was the big cost driver for RX. One of the key ways to reduce RX diabetes costs is to do something about reducing people at risk of diabetes. And one of the strategies we laid out or presented to our members was what sorts of wellness programs can you be undertaking to look at that at-risk population to try to prevent them from having to need those drugs. So absolutely, and that's something that really goes beyond our strategy around RX and just medical costs in general. What can we do preventatively? What kind of strategies can we identify for members to help them? And they're leading the way. They're telling us. We're sort of a conduit for all these really good ideas. But what are they using? What sort of wellness programs are working? What other kinds of strategies? What kinds of benefit designs can encourage folks to use those preventative products so that they don't end up needing those more expensive products later on?
Well, just a quick plug. That's why I'm sitting in this. I'm part of this organization with Maine Health Management from the American Cancer Society, because we know that we heard a little bit about return on investment and so on, but prevention is one of the best investments we can make. So, avoiding those long-term cancer costs, high cancer drugs, with the things we can do preventatively, so that internalizing that into employee wellness and so on, so it's not just, oh, here, have your flu shot, but here, this is the way we can help you prevent many of these diseases.
And really, so many studies have shown when it is integrated into the workplace, having a strong message that the leadership of the workplace is really committed and part of the process apparently is really critical. Yes?
Where's the survey? I want the slides.
As I said, tomorrow Trevor will be sending out the survey and you will have immediate access. You have to fill it out. And you can say whatever you like.
Going back to the issue of infrastructure, have you done any kind of surveying across the state of Maine about what alternatives, outpatient injections are available outside of Cumberland County?
No. What we're seeing so far is that most of the alternative sites that people are being redirected towards are home infusion. So it's working with those home health nurses or other clinicians to get the services delivered at home. But the supply isn't there yet. And as that is going to be one of the key things as we start trying to amp up, figuring out whether we can really make a difference and move the needle, is what's out, what does the inventory look like, where are the holes, and what can a group of determined purchasers do in terms of generating interest in having more providers supplying those alternative settings.
Do you have a sense of how many home health nurses are available, what kind of networks even there is?
I don't, I can get that for you, but unfortunately it's also, the number itself, it's interesting, but it doesn't really tell the whole story because they're going to be, I wouldn't even call them pockets, but large parts of the state where even if you have a good supply that covers Cumberland County, you don't really have that coverage that you need in other parts of the state. So that is really the critical first step for us is getting that inventory and seeing where the holes are and are there ways, are there strategies we can pursue to try to make those alternative sites available.
Lisa, is there an opportunity for on-site clinics at employers to facilitate that?
I think it depends on the size of the employer. We've had employers that are interested in having on-site clinics, and if they don't have that population, it's just the volume isn't there to make it sustainable.
But even share.
Yeah, I think shared, and that's kind of the beauty of the coalition. You have areas where we have multiple employers represented in an area, and whether it's on-site or somewhere in a community, if a provider understands that there are 4 or 5 or however many employers that are interested in looking at something less expensive, then maybe they will build it, and then we'll come. Any other questions? Thank you all for being so appreciate it.